Specialty Stories, session number 94. Whether you are a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week, where I get the amazing opportunity to talk to different physicians about their specialty. And my goal when starting this podcast was to talk to physicians from every nook and cranny of the specialist world out there. And today's guest does not disappoint. Dr. Carly Snyder is a reproductive psychiatrist, something I didn't know existed, something I didn't know existed, and something she didn't know existed until she was actually in her psychiatry residency. We talk about her journey to reproductive psychiatry, what she likes, what she doesn't, and what that world looks like, so that maybe you can become interested in reproductive psychiatry next. We start the discussion with how Dr. Snyder became interested in reproductive psychiatry to begin with.
So I did not know reproductive psychiatry existed when I started residency. And I was a psychiatry resident, and we do, 4 or 6 months of medicine and pediatrics. And throughout that period, those 4 to 6 months, I kept on questioning psychiatry because I didn't really like inpatient psychiatry. I found it depressing, and it wasn't how I had imagined my career would be. So I was on the pediatrics floor, and there was a little boy who came in. He was, I want to say 3 months old, plus minus. And he had been having, he had intractable epilepsy. He had seizures from the first day of his life and onwards. And he came in for he was coming in for the video EEG, but they knew there was nothing they could do for him. It was purely a question of how far along he was in terms of the process towards death. And it was heartbreaking. And I had a baby boy at home as well. And I really identified with his mom. I wanted to help her. There was like this very strong drive in me to help her. And I ended up sitting and talking to her for, every day that he was inpatient for a while, just about how she was doing. And, she said no one had asked her, right? It wasn't something no one focused on her, right? There was this baby. And when he was discharged, I connected her with a grief counselor who somehow literally worked across the street from her office. It was like the perfect setup. And to this day, I don't know what possessed me to think of a grief counselor, but it worked out. And I bumped into the neurologist from that case, several months later. And he told me that, this baby had passed away, but the mom, relatively speaking, did really well because she had this support network already in place, and that they decided they were going to set up a program where every woman whose baby or child was dying was going to be connected with some form of a grief counselor, a therapist, what have you, where they would start to focus on mom as well. And I had this kind of aha moment that, wow, I could actually affect change. I could help women. And probably in parallel to all of that, turned out one of my senior residents' wives, this woman, Malay Okio-Grosso, was doing something called reproductive psychiatry. So he said to me, hey, why don't you just talk to my wife? It sounds like you would really like what she does. And so I did. And took a while, but I set up an elective at Cornell where they still have a women's mental health program. And I went, and I realized that was what I wanted to do, that it had the perfect mix of women's health, women's mental health. There's a fair amount of medicine involved. You have to think about the mom, you have to think about the baby, you have to think about the family system. And you also have to consider, is there a medical issue going on? Is there some underlying thyroid issue? I mean, there's so much going on, and I love it. And more than anything, my patients do really beautifully in this incredibly, sometimes difficult, right? But anyway you cut it, it's a huge transition in life. And to be able to support women through that process is incredibly rewarding. And so I did my elective, and I realized I really loved it. And I joke I never left, because I literally went back every week after that, after that month was over, and for journal club. And then when I finished residency, I was given one of those jobs. You're like, wow. I was given the directorship of women's mental health program at Beth Israel. And I was embedded in OBGYN, and I still went to Cornell every week. It didn't matter. And now I've been attending in the Cornell program for, several years, because as I said, I never left.
Literally never left.
Never left. Yeah.
So I usually ask this question a little bit later, but I want to skip to it now, because somebody listening, just like myself, it's like reproductive psychiatry, never heard of it, don't have any clue what you're doing day in and day out. So let's start with, who is going to see a reproductive psychiatrist? What types of patients are coming to you? What are you treating? What are you discussing day in and day out?
So I see women technically really throughout the reproductive lifespan. So I don't see teenagers personally. Maybe an 18 and 19-year-old in general, but my practice is limited to adult women. And the vast majority of my patients come to see me because of we can put it into like 4 subheadings, maybe 5, I don't know. Basically, you have women who have a history of depression, anxiety, bipolar disorder, what have you, right? Some psychiatric illness, and they may or may not be on medication, but they're looking towards a planned pregnancy, and they want to figure out how to, optimize their mood while also minimizing risk, and how can we strategize to keep them stable on or off meds, right? It depends on the patient, and limit the risk from either exposure to medication and or exposure to untreated illness, because you have to weigh both sides of it. I have a fair number of my patients are in fertility treatment, and they're referred by, reproductive endocrinologists, either similarly because they have a history of whatever, right? And the fertility guys are like, oh, go see Dr. Snyder once they see any medication, any psych med on their list of medications, or because the woman's having a really hard time through the fertility process. And then some patients come to see me when they're pregnant because they are experiencing mood symptoms, sometimes when they're postpartum. And everyone in that heading tends to stay with me. So I have women who came to see me initially because they were thinking about a pregnancy. And now 3 kids later, I still see them regularly, and which is incredibly fun and rewarding to see women's families grow and see their lives unfold. Some of whom have done so in parallel with my own family growing, which is also nice. Obviously, I also have a cohort of women who are referred just for consultation. So they have their own psychiatrist, but their psychiatrist doesn't inherently feel comfortable making a decision about medication. They want to know what I would suggest. So I'll see the woman once, or sometimes they'll come and see me once and then come back a few months later, just sort of as a follow-up. But in that scenario, obviously, from a professional standpoint, those women stick with their doctors. And then I have a group of patients also who have severe PMS, which is called PMDD. And they come to see me because every month for a variable number of days prior to menses, their mood really changes to such a degree that their ability to function has really been impacted. So I work with that group as well.
What traits do you think lead to someone being a good reproductive psychiatrist?
It's a great question. I think one needs to have empathy in any specialty. So I think empathy is probably top of the list. You need to think from a holistic standpoint in terms of the whole person, but also the entire scenario and the whole situation that you're looking at. So if you're someone who's insanely myopic on an issue, it may not be the best option for you. You need to think about it from, I think about my patients' lives, not just from the standpoint of the specific medication and that's it, but you think about it from the standpoint of their family structure, of their future plans, right? What their past looked like. I mean, a lot of times if I'm talking to a woman about medication options, maybe she's not pregnant, right? But she says to me, well, I'm thinking about having a baby in 2 years. That still impacts my recommendations. So you have to kind of think about it kind of take a big picture view on things. You also have to just be able to consider multiple factors, including, making sure there's no underlying medical illness going on that's actually masking or kind of either feeding into a psychiatric illness or is really kind of, I don't really love the notion of it being the primary cause of mood stuff because it's rare. But, thyroid disorders, for example, can really wreak havoc on a woman's mood in the setting of pregnancy and postpartum. So stuff like that. I think you also have to be able, for me, at least in my practice, way I think about it is, you can't be dictatorial in terms of what the way you think is the way it should be. This is, you're working with women who are incredibly anxious by definition because they're pregnant, right? Most of them, or they're planning a pregnancy. That's normal, right? Everyone's pregnant. Everyone's anxious at some point in pregnancy. And their concerns aren't just for themselves, but they're also for this future baby. And while you, as the physician, may have a very rational approach to why you would recommend X or Y or Z, their anxiety means that maybe they're being completely irrational. And that's okay. You have to be able to stand there where they are and hear them and work with them to get to where they want to go, not where you think they should be. And I mean, I think that's an important component to it is, and also, frankly, not being too much of an alarmist, but also knowing when to freak out when you should. Meaning, again, people have anxiety throughout, in the form of planning a pregnancy, fertility treatment, pregnancy, postpartum. Like, that is normal to some degree, but it shouldn't negatively impact your ability to function and enjoy life. So being able to kind of take everything you're hearing, assimilate it into a picture and get a sense of what is going on that is actually appropriate versus what's excessive and determine it pretty quickly, frankly. Yeah. Because this isn't the kind of population, women don't want to wait and see for a while, right? They're in this incredibly, is a time of huge flux and change. And I think our job as reproductive psychiatrists is to support them through that process in whatever way, but support them in real time, not, at their next appointment in 6 weeks.
Yeah. Now, you mentioned earlier talking about how you got to this path of reproductive psychiatry, that you didn't like the inpatient general psychiatry. And so one listening may go, well, why did you decide to become a psychiatrist in the first place? Can you briefly talk about the path switch that you went on and why you went on it and why psychiatry?
Well, so briefly, that might be hard. So I had planned on doing plastic surgery. In med school, I loved plastics. And I had in medical school all but written off medicine because when I was a third year med student, I was sent, I went to med school at NYU and was at Bellevue, and there was a guy who had come in with fevers of unknown origin. He had been in Senegal for a while prior to that and came back and then started spiking these fevers. And he was admitted to the floor typically reserved for patients with TB. And the plan was to discharge him because they couldn't figure out what was wrong, and he seemed relatively stable, but his LFTs came back really high. So I was obviously the lowest person on the totem pole, and I was told to go grab, a hepatitis panel from him. And so I went in and I was drawing the multiple vials of blood, and he pulled the needle out and was like, he takes a butterfly out and blood's just going everywhere. And he's like, I'm done. And I had only gotten through like 2 vials or something. I was like, can we please just wait? And so he kind of decided he would wait another minute and get another vial or 2 down. And I put the needle back in, and he had basically no veins in his arms. He had like 1 or 2 in his hands. And I made the distinct mistake of holding his hand with mine, like holding his hand down, the one that had the butterfly in it. And he took the needle out of his hand and jabbed it into mine. Ooh. And said, doesn't feel comfortable, does it? And I was like, no, it doesn't. Anyway, it turns out that he had Hep B, Hep C, and HIV-2, which was the cause of his fevers of unknown origin. So I was on a really nasty cocktail of medicines, of antiretrovirals for 3 months or so, because HIV-2 is actually, at least back then, Senegal was one of only a few places where it was actually more common than HIV-1, but they didn't really have a great sense at the time of how they should prophylactically treat me. So I was on a gazillion meds, and including some that I think are off the market now because they were so bad. So after that whole experience, I was like, I'm not going into medicine. Medicine is off the table, period. Like, I just did not want to have anything to do with the specialty at all. But my next rotation was surgery, and it was sort of one of those like sink or swim things. And I jumped in and I loved it. Something about it I just really enjoyed. And I married a neurosurgeon, and during my third year, actually, of medical school, same time. And I was gung-ho plastics. And then as I finished medical school, having spent my 4th year doing plastics rotations, I was also about to have a baby. And then I had my son, and I had this, and I had already planned on taking a year off between med school and residency, because my husband did a fellowship up in Toronto. And I had this weekend where I freaked out. Like, what would happen if I wasn't home for breakfast all the time? Something about that really upset me. So I decided to kind of course correct, so to speak. But I didn't want to do medicine. Like, medicine for me at the time was really distressing a concept. So, and I didn't want to do another, surgical subspecialty. So there was psych. And my dad's a psychiatrist. Uh-huh. I had liked my psychiatry rotations. I mean, it wasn't difficult. Like, I thought, wait, what the hell? It was sort of one of those, okay. So it was sort of it was nothing where I went into med school or even applying to psychiatry where I was incredibly passionate about psychiatry. And then when I started it, as I said before, I found inpatient psychiatry difficult from an emotional standpoint. I went to, my residency was in New York City, and patients are obviously very, very sick, and we had a lot of frequent flyers, but there was not much we could do for them, and they didn't have social supports, and it was very different than what I had anticipated it being like, in part because I had done my psych rotation at Lenox Hill, which was a different kind of population than what I was seeing. And it was eye-opening to me. It was so sad. It was, and I felt very powerless to help these people who really needed help until I found, first, I think until I found my footing, number one, right? Once I felt more comfortable in psychiatry in general, I liked it more, but also just finding my niche within it. Now I love it.
What does a typical day look like for you?
It depends on the day. So I now have 3 kids, and after my third was born, she was a preemie and had a very hard first year of life medically. And at that point, as I said, my dad's a psychiatrist, and he said to me, "Listen, why are you in private practice by yourself in your own office when you could come and join my practice?" And I said, "Okay." And he said to me, "And honestly, why are you working full time? You don't need to right now. You need to focus on Penelope and your other kids." My baby's Penelope. And he was right. I was pushing and pushing and pushing, but I was also pushing to be, as present a mom as I could be. And psychiatry, I think, of anything, has an amazing amount of flexibility if you, depending on how you structure your practice. So these days, I work in my office 2 days a week. And those are 2 insanely filled days where I'm there from, roughly 8 until I could be up there till 7, till 8. It depends. And, I joke with my assistants that if they give me a break to run to the bathroom, then it's like it's a slow day. I just have back to back to back patients throughout the day. But I tend to see patients, occasionally they'll come in for a 15-minute, quote, medication follow-up, but it's insanely rare that it actually is 15 minutes. People tend to want to linger. The vast majority of my patients I see for 45 minutes. Because what we're talking about is so important, and there's information, and it's not just about how they're feeling, which is incredibly important, but also how they feel about treatment. What questions do they have about the risks, the benefits, the alternatives, what have you, the dosing as pregnancy in terms of pregnancy, and and also I become a safe place for women to come and talk about parenthood, for example. I'm a safe place for them to come and talk about, their fertility treatments, their frustrations with the whole fertility process, or their marital issues as it relates to the fertility process, or, in pregnancy, their struggle when people are, giving them all this advice and what have you, right? So it's not just a question of pharmacology at all. A lot of what I do is supportive from as someone who's been there, but also who understands kind of all the different facets to what's going on in their lives in terms of hormones, in terms of the mood changes inherently existent with the various stages of parenthood, pregnancy, etc. I can be a place where they can come and A, talk through what they're experiencing. B, I can normalize when it's appropriate. And C, I can also take a step back and say, hey, you know what? Doesn't have to be this hard. And we can work through it together. So that never happens in 15 minutes, basically.
Yeah.
Maybe my most stable patients, 15 minutes, but that's really rare. And then the rest of so that's Tuesdays and Thursdays. And I tend to see a fair number of, new patient consults each week, plus my old patients. And I have a radio show on Wednesdays, and, I prep for that. I have time to do a lot of writing, which is not something I ever thought I would be interested in doing, but I end up writing a fair amount of parenting related stuff. And I get to hang out with my kids. Although as they get older, they're in school more, but
yeah,
it's a balance.
What does call look like?
Technically, it's 24/7. Meaning, well, yes and no. I shouldn't say that, because I'm in a practice. it's not really 24/7 in so much that if I need one of my partners to, deal with something for me, they will. But I'm the only reproductive psychiatrist amongst us. Everyone else does child, adolescent, and adult. So in truth, I mean, technically it's 24/7, but at the same time, there are a few things that I can do in the setting of an emergency from home, right? If someone has postpartum psychosis, they need to go to the hospital, right? Their partner, someone needs to call 911 and get them to the hospital because that's going to be the safest place for them. And part of what I do is also educate people in advance. So there isn't kind of a question mark about what to do. So knock on wood, I mean, it's always like, don't say you're going to have a quiet call when you're about to start call, but but nevertheless, I'll say I don't get, SOS calls or, all the time at all.
Yeah.
It's very rare.
What does the training path look like to become a reproductive psychiatrist?
It's variable. So there are a few fellowships, not many. I think a lot of times you kind of do what I did, where you make your own path, or you find an elective, you find a mentor. And as I said, I'm an attending at Cornell now, and they have a rotation for for residents. But I think people approach it in different ways. Some people go through CL.
What's CL?
Consultation liaison. Sorry.
Okay.
They do a fellowship in that. And sometimes you just have a mentor who supports you through the process. I have a couple mentees through the work I do at Beth Israel still. And one of them actually is doing a child and adolescent fellowship, and at the same time is trying to see as many reproductive patients as possible. And, she just calls me when she needs me, basically. So it's variable, but there are fellowships available. We have conferences, and, if you want to learn about it, there's more and more information readily available to do so.
How big of a field is it?
It is not big at all. I know it's pretty rare that I've never heard of someone who legitimately does what I do. Meaning there are people who will say, oh, I do reproductive psychiatry, but they do, lots of other things too. Mm-hmm. But the people who are really focused on this, we have a listserv, for example. It's called the ReproPsych listserv. And I either have met in person or I know via, email threads and via papers that they've written. Basically, I'd say 75% of the people on there. And that covers the ReproPsych listserv has clinicians from around the world. The only caveat is I used to be on the board for Postpartum Support International, and now I'm on the President's Advisory Committee. And PSI is the leading resource for women and their families who are suffering from various perinatal mood disorders. So I do have an in terms of just connecting with all of these specialists.
Yeah.
I guess considering myself a specialist too. But we're still a really small field. And unfortunately, a lot of people don't know that we exist, which is obviously really unfortunate for people who are suffering. And, they're unsure where to turn, and or they're getting bad advice, which frankly still happens too often.
Yeah. Do you see any reproductive psychiatrists further subspecializing their practice into some sort of niche?
We're pretty niche at this point. I think there are some people who are more focused on PMDD, who do more research on it, which is frankly incredibly fascinating. There are a few people who are specifically interested in postpartum psychosis. And again, that's very research driven. There's, I think most of us are treating what I was talking about. I don't think as many people see fertility patients in terms of a fair amount of my practice. I'd say a third is fertility focused, which may not be exactly the norm at all. So that, I guess you could say one could subspecialize there as well. But, if you see a fertility patient, they hopefully get pregnant and then now they're your perinatal patient. Yeah. So there's a huge amount of overlap and blending that happens. And there are definitely people who also subspecialize in more perimenopause related mood disturbances. But those, I can't speak for everyone, but I think it's pretty rare to find someone who only sees, women in the perimenopausal phase of life. Mm-hmm.
For the osteopathic students listening to this, or maybe residents, do you see any sort of negative bias towards DOs in the field?
No, I don't believe so. Yeah. Not at all. I think we're a pretty welcoming group. There's not much bias at all.
Yeah. With such a small community of reproductive psychiatrists, how do you get the word out to the primary care providers that you are out there doing your thing? And what do you wish they knew about reproductive psychiatry so that they can help their patients better?
Such a great question. So I can answer that from two different standpoints. I can from an individual and then also from like a larger global standpoint, systemic, whatever. Personally, at this point in my career, I don't do much. Meaning, I know there's like a core group of OBGYNs and reproductive endocrinologists and endocrinologists, and there are a couple rheumatologists and psychiatrists. I have a pretty sound referral network at this point. I'm also very lucky to have a smaller group. We all are colleagues and friends, and we go out for dinner together, and we encompass several subspecialties that really support women within the same phases that I see. So, which is great. It's really good for patient care as well, because when one of us sees a patient, then refer to the other one, and we call each other and say, "Hey, what's going?" It's very easy to collaborate together. Mm-hmm. When I was starting out, I definitely, I went to every conference and I just walked up and I, introduced myself. And I was also lucky enough that I was on, pretty early in my career, I got on the PSI board. So I had that connection. And as I said, I worked as embedded within OBGYN. So I also had those connections. But I think it's kind of hustling. Like you just, when you meet a pediatrician, for example, if I meet a pediatrician, my goal is for them to appreciate that I'm available for their patients. In addition to learning about their practice and getting their card, I do, end up going to coffee with a lot of people. And a lot of people are just sort of interested in what I do because they don't really know it exists. On a much larger standpoint, I helped with the creation of a online module. There are several modules. It's an online course for Postpartum Support International for primary care providers specifically. Mm-hmm. And it's a 2-day course that can be done online. There's also separately a 2-day course of lectures, which I've given some of the lectures myself. But it is specifically for frontline providers so that they can feel more empowered and they can understand perinatal mood and anxiety disorders more and treat accordingly. And I'm also, through PSI, we have a consult service. So right before we got on the show, I had a consult from a physician who had a question about a patient who she was seeing, and she just didn't know what to do. So she called our consult line and, she got me. And I think what I want people to know is that we exist, that reproductive psychiatrists are specialized in treating women throughout, throughout their reproductive life cycle. But most importantly, to realize that when in doubt, rather than stopping some, if the go-to for a long time was if a woman said, I'm pregnant, people would say, oh, stop your medication, right? That was like the knee-jerk response. And save for a few medicines, right? Like, for example, Depakote, which is incredibly teratogenic. And I mean, I think we should follow, the lead of several European countries where they actually don't prescribe it to women of reproductive age because of the degree of teratogenicity. In most scenarios, there really is a risk-benefit discussion to be had between the risk of untreated illness versus and the benefit of medication and vice versa. So that knee-jerk response of stop your medication can actually be far more dangerous and present more risk than remaining on medication. But it also, look, pregnancy is a very dynamic time physiologically, and you have to keep up with the physiologic changes that occur in order to keep a woman stable in terms of changing her dose and what have you. So I think the first thing is to just realize that we exist as a resource and to seek us out if you have a question, rather than, encouraging a patient to de facto stop medication. Now, sometimes they should, but in general, that's not the go-to answer. It really depends on a woman's unique history, where she's at now, et cetera. Yeah.
You mentioned endocrinology, OB, I'm sure other primary care physicians. Are there any other specialties that you work closely with?
Well, so pediatricians are, because obviously, they tend to see a new mom far earlier and then more often than an OBGYN does.
Yeah, that makes sense. I was trying to figure out, I'm like, why pediatricians? I'm like, oh, they're interacting with the mom 2 days after birth.
Mm-hmm. Exactly. And, there's a push now, which is great, for some kind of check-in visit between that 0 to 6 week mark with an OBGYN, but often that can be on the phone. It doesn't have to be in person. And, the pediatrician really does become, and is still the first, that's your frontline provider, because that doctor is seeing mom and baby. And if that doctor's not seeing mom, the question is like, what's going on, right? Where's mom? So pediatricians are big. I definitely interact with some rheumatologists as well, especially for my fertility patients. But, and internists and other psychiatrists.
Yeah. Are there any special opportunities outside of clinical medicine for a reproductive psychiatrist?
Well, yeah. I mean, there's always research, right? I think that our field is one where research has been exploding, which is awesome. There's a lot of room for that. If one is interested in writing papers and what have you. As I said, I do a lot of writing. I think that people, because there are so few of us, there is great opportunity to help people without even seeing them by virtue of writing about what you want others to know. And that can be for lay people or for other physicians. I think you can kind of do whatever you feel best with it. It's a very, you make your own path. So, I mean, as a side gig, I have a business with my business partner is an acupuncturist, and we're developing a nutritional bar line of food for women. Mm-hmm. And I definitely use a lot of my expertise in terms of formulating. When we were formulating our different bars, totally thought about what, mood and hormones and all of this stuff. So you kind of can really find lots of different ways to use your practice.
Yeah. What do you know now that you wish you knew before going into reproductive psychiatry?
That it exists. That would probably be the first thing. I mean, that's the biggest thing, is obviously that it exists, but also to approach each woman as the unique individual she is, rather than thinking about it purely from like which medication is best, but first listening to what she thinks, what she wants, where she's at, before presenting options, right? Because ultimately it's not my body, it's hers. It's not my future baby, it's hers. And my job is to present all the information that's available now, and then allow her to make an informed decision. And obviously I had some sense of that when I started as well, but through seeing lots of women, and also, frankly, going through my own experiences as a mom, and having experienced pregnancy loss, and being a patient in that scenario, and feeling what it's like to be on the other side of things, I have an even greater respect for and understanding of the sense of autonomy that women should have. And that my job is really to enforce that, not to ever have anyone feel like it's being taken away.
What do you like the most about being a reproductive psychiatrist?
I love that my patients get better. And when they do, they find joy in motherhood. And that's pretty awesome, right? Like, parenthood is, by definition, it's not easy, right? It shouldn't be. They're little people. They have opinions, and their kids are not robots. So by definition, they're never going to 100% be easy. But parenthood is a magical thing. And it's so sad when someone isn't seeing that magic, where they really just feel pain in the whole process. And being able to help a woman such that now she is enjoying being a mom, and enjoying her life as it has changed, and now she can own her decisions and feel good about her role as a woman, as a partner, as a mom, all of these things. It's so rewarding. And when women walk in, they're like, they want to give me a big hug. That's the greatest feeling. It's awesome.
What do you like the least?
It's a great question. What do I like the least? Well, I don't know. I don't think anything specific to my subspecialty, frankly. There's nothing about it that I don't like. I think, I can't think of anything specific to my subspecialty. Obviously, in medicine, I don't think any of us like the paperwork, right? And the covering your ass, like the kind of the need to write things just to make sure that you've dotted every I and crossed every T,
Yeah.
Even when it's unnecessary. But I don't think that's special to my specialty.
Yeah.
That's across the board. So yeah, I think, the thing that I like the least, I guess, in my subspecialty is, and this frankly, again, can be found in any specialty, but when one of my patients is really sick, it's scary, right? If I have a woman with postpartum psychosis, she's got a 5% risk of suicide, a 4% risk of infanticide. Those are legitimate risks. That's, and I definitely have nights where I'm anxious. I'm worried for my patients, and when do you say you need to be hospitalized versus when do you say, okay, you don't want to be hospitalized, but how are we going to figure this out for your safety, et cetera? Yeah, that's not fun. But when they get better, which they do, that's awesome. It's a great feeling.
Do you see any major changes coming to the field that somebody should be aware of?
Well, I think politics aside, so not going on a larger, it's specific to the field, no. I mean, I think it's just growing and expanding in really positive ways. There's, as I said, there's more and more data and there's more and more research supporting what we do as being incredibly important, both for mom and for her baby, from an emotional standpoint and also from a physical standpoint. So, and, there was a recent medication, just it hasn't actually launched yet, but it's got FDA clearance, the IV formulation for treatment of postpartum depression, which is really exciting. And hopefully they're going to have an oral formulation, which would be a really exciting thing as well. So there are, new treatments that are being offered and which will let us help women that much faster, get better that much faster. And I think there's more and more understanding of the different subtypes of, antepartum and postpartum depression and anxiety and the different causes and how we treat, gets even that much more, like we can hone in specifically on various symptoms, et cetera, when we know the underlying mechanisms. And I think we're increasingly getting great data on the underlying mechanisms. So I think the field is just getting better and better.
If you had to do it all over again, would you still be a reproductive psychiatrist?
Yes, I would. 100%. Absolutely.
Any last words of wisdom for the pre-med or medical student or even resident out there thinking about reproductive psychiatry now?
Definitely come and, find someone to shadow, check it out, right? I think I love my field. I love what I do. It's one thing to read about, it's another thing to do it. And I think it's an amazing opportunity. So, as I said, we're a friendly bunch. Find us and, come in and check out what we do in person. Because you have to really like working with moms and women who are going to be moms and who are, as I said before, who are anxious, but it's to some degree a normal level of anxiety. Like, there are some people who are more or less interested in working with women that I love it. I think they're the best, population to work with. But I would say just check it out. Check out everything in person. I think the best thing to do in med school, definitely, and pre-med even more so, is have an open mind and really see what pulls you. I clearly got lucky in the end. My mind was not so open when I was in med school, right? Like I kind of closed doors for myself. And I'm still really glad with where I ended up. But I think if you really go into every rotation with a, open mind and just kind of check it out and see what you think, rather than having any kind of predetermined sense of where you should go or what you should do, then you'll find what you are meant to be doing. Have fun with it.
All right. There you have it. Again, that was Dr. Carly Snyder, reproductive psychiatrist, talking about her journey from plastic surgery to reproductive psychiatry and how basically she was lucky she found it because this is what she fell in love with. So hopefully this opens up your eyes to a new world in the psychiatry world. And as a primary care physician in the future, some of you out there may now know that there's this other field that you can refer your patients to. I hope you have a great week. We'll be back next week with another great guest. We'll see you next time here on Specialty Stories.